Right. Yeah. Good morning, everyone. Good morning, everyone. My name is Leon Roberts. I'm the Dental Support Center Director for your USET. I'm going to start off with a little housekeeping things. Once again, like I said this morning during the session, all sessions are being recorded and will be available for viewing up to 3 months following the conference using your CVent login. And today is the wrong one, but this is day 3. Day 3 of our clinical practice track. And this is the last day of our best practices conference. So thank you all for joining us. Today, I'm going to introduce our speaker, Julie Seward. Julie is, well, she was born in a rural Oklahoma town. She's
starts off like a carry-on.
And she is actually a member of the Cherokee Nation. Julie started her venture off into healthcare or dentistry, starting as a little child when her grandmother would take her to the dentist. It would be 60 miles away from where she lived, so about a 2-hour round trip to go to the dentist. Her grandma was so special. And she would take her and her siblings to the dentist, 2-hour round trip. There, Julie got familiar and liked the dental setting. And she actually got to interact with hygienists there and throughout her career. So that started her venture down oral health, where she worked in the front office at a dental clinic. She's worked as a dental assistant. She is now a dental hygienist. She got her education at Tulsa Community College, Oklahoma State University, and the University of Houston, where at the University of Houston, she received her master's in allied health education and administration. That helped her with her experience in dentistry, where Julie not only was an educator and a hygienist, but she's an advocate and an author. She also was a public health chair of the Oklahoma Dental Hygiene Association, dental hygiene liaison for Oklahoma, also vice chair for Oklahoma Oral Health Coalition. So she has over 20 years of cumulative dental and oral health experience. I got a chance to meet Julie last year. She's part of the Native Oral Health Network. And she recruited me, and now you said it's part of that as well. And thank you for that. I got to meet her in person for the first time this year, twice in Oklahoma, where she is part of the Southern Plains Tribal Health Board. She manages all of the oral health activities for Known, which is affiliated with that. And so Julie is not only a hygienist, but an advocate for public health, and she advocates for the community. So today, she's going to be speaking about CHAP program, which is a community health aid program. So join me in welcoming Julie as she starts her presentation.
Well, thank you. Well, Osio Ostas Tamali'i. Hello, good morning. My name is Julie Seward. I'm a member of the Cherokee Nation. I am super honored and humbled and excited to be here. And I thank you, USET, for inviting me to speak. It's a true honor. I am going to talk about the community health aid program today. And so before we kind of get started, has anyone heard of the program? Does anyone have any knowledge of the CHAP program?
Yeah, I've seen it on the IHS website, but it wasn't clear to me exactly what was happening. So I'm glad to be here and hear from you.
Okay, great. Did anyone hear Christina Peters' presentation yesterday? Okay, because she went into, I know, a lot of detail. And so kind of what we're going to talk about today is really our work. And when I say the Southern Plains Tribal Health Board, through the our community health aid program, the tribal assessment and planning grant that is through the Indian Health Service. So we're going to kind of talk through that, give some, this is what we're doing, this is how it's going, this is what we've learned, and etc. So, and I loved Dr. Hill this morning kind of saying it's, having pictures of your kiddos and your family, it grounds you, and I couldn't agree more. And so I've got 2 little ones. Miles is 8 and Quinn is just turned 5, you know, but going on like 17.
Oh,
Those are the girls. Yes. And me and my husband just moved back to Tulsa, which is Tulsa, Oklahoma, which is where we're from originally. I'm from Shakota, Oklahoma, born and raised, but we lived we consider Tulsa our home, and Eastern Oklahoma as well. And so and then the top right corner are those are my cousins and my aunties, and they're my rock, and they have mentored me, and so I'm always kind of carry their energy and their spirit when I go and speak and talk about the work that we're doing. So I kind of talked about what we're kind of our outcomes for today, which is I'm going to talk briefly, give a background of the Southern Plains Tribal Health Board, and just provide a context of the Oklahoma area as we talk about go into the CHAP discussions, and then really just a high level overview of CHAP. I have included some resources where if you want to take a deeper dive, but it is a massive program. So, you know, Northwest Portland Area Indian Health Board just had a symposium, a CHAP symposium that was 3 days. It could have gone 5. There's just so much to the program. And then, like I mentioned, talk about our planning activities through our current grant. So this is our CHAP team, and so they are. I wanted to bring them with me, but they are busy meeting with tribal nations, tribal leaders, and health directors, and trying to learn more about their needs and how CHAP might fit those needs. So they are out doing the good work today. So again, just talk just a little bit of an intro of the Southern Plains Tribal Health Board. So it's a nonprofit organization, and we're based in Oklahoma City, Oklahoma. The Health Board was established in 1972 to provide a unified voice on tribal public health needs and policy for the 44 federally recognized tribes that are located in the states of Kansas, Oklahoma, and Texas. The Oklahoma Area Tribal Epidemiology Center is a division or department underneath the Southern Plains Tribal Health Board, and really the only department. So we have SPTHB is the administrative arm. And then all of our programs and everything falls under the Tribal Epidemiology Center. The Tribal Epidemiology Center is one of 12 TECs located across the United States, and they were established in 2005 through core funding received from IHS. So as a public health program, the TEC works with area tribes, state agencies, tribal organizations, academic institutions, nonprofits, and many other agencies to provide a wide range of resources to those we serve. And so Leon mentioned the Native Oral Health Network. This is a program underneath the SPTHB TEC umbrella, and that is a nationwide coalition or community of practice that is where we connect and do our work through peer support, through community engagement and advocacy. And so hopefully next time, if I get to come back or I meet you all in some other area, or we get to connect again, we'll have a new SPTHB CHAP logo, and I'll be able to share that, but hopefully that'll be coming spring of 2024. So again, just kind of setting context of where we're doing our work, the Oklahoma City area, which includes Oklahoma, Kansas, and Texas, 38 tribes in Oklahoma, 4 in Kansas, and then 1 in Texas. So again, not going to go too much into the program, just going to kind of talk a little bit about the CHAP program, and we'll go into exactly how we are working through identifying the feasibility and planning in those activities through the context of our service area and our tribes. So this slide is actually from the IHS website, and so it says the community health aid program includes 3 different health aid provider types, each including a tiered level of practice. Health aides do not practice independently, but they are extensions of their supervising clinician to provide direct patient care. But it's so much more than just providers. It's tribal self-determination through a self-contained, tribally led healthcare training, care, and delivery system. So this is the outline of the tribal assessment and planning grant. And so what the goals and objectives set forth through the Indian Health Service whenever they released this, there was a funding opportunity is, here's some money for you guys to engage with tribes, determine, okay, under this CHAP, what you know about CHAP, the baseline from Alaska, and we'll talk a little bit about the history of the program in just a minute, but based on Alaska is, what is the feasibility? Can this be done? What does it look like? What are the gaps? What are the major barriers to integrating CHAP? And the ask was to look through these key areas. So clinical infrastructure, workforce barriers, training infrastructure, cultural inclusion, how much it's going to cost to fully implement, and at the end of the grant, determining whether it's feasible to implement into our area. So this just kind of goes further into kind of the assessment, identify those systemic barriers, and then plan those partnerships to lead into the integration process. And this just goes into a little bit more detail of each of the key areas to provide a little bit more context as we're collecting data and speaking with tribes. I also wanted to, before we get into kind of what we're doing and how we're doing it, is to provide a little bit of background on Oklahoma. I guess just really skimming the surface, there are only 4 tribes out of the 38 in Oklahoma that are actually native to the land. All of the other tribes were forced there during removal. And so I think that's really key whenever we're talking about kind of the landscape and talking about implementing this new system of care where we're integrating cultural practices and traditional healing and methods into this system of care and training and care delivery. So I just wanted to include some maps here that, so this top left one is during the initial removal. And so you can see the so these are the 5 tribes, 5 civilized tribes to say, Cherokee Nation, Creek Nation, Seminole, Chickasaw, and Choctaw. And so that was 1830. By 1855, the area looked a little different. This was 1889. We have some additional tribes from forced removal here in Oklahoma. And then these are the tribal jurisdictions today. And so this is kind of shows you the Indian Health Service service units and facility locations. And look, it's here really quick. And since we have a small group, if you guys have any questions, just feel free to raise your hand and interrupt. We can make this, super informal and discussion based. So feel free to interrupt me, please. Okay, so the Oklahoma City area Indian Health Service, or the IHS Oklahoma City area, serves the states of Oklahoma, Kansas, and Texas. And 43 tribes are represented within the area, with 38 in Oklahoma, 4 in Kansas, 1 in Texas. So in fiscal year 2022, the Oklahoma City area user population was 407,942. That's the largest user population in IHS. However, the Oklahoma City area is the lowest funded IHS area per capita. So within the ITU health systems, within the area, they manage 8 hospitals, 62 health centers, which includes 5 health clinics in urban locations, and 1 regional youth alcohol and substance abuse treatment center. The large number of tribal healthcare facilities and programs is a strong reflection of the partnership and cooperation within the Oklahoma City area to fill the existing healthcare needs of the community. According to the 2021 American Community Survey, the 5-year report, there are over 1 million individuals that identify as either American Indian, Alaska Natives alone, or in combination with one or more other races in the Oklahoma City area. So this represents the potential users for our area's health system that reside within our service region. And this is just another map kind of showing the IHS facilities, the urban facilities, and the tribal facilities within our service area. Oklahoma in the top left. This is our traditional Kickapoo tribe of Texas. That's one of our tribes there in the southwestern part of Texas, and then the northeastern part of Kansas. So currently in the state, we have 20, so 20 out of 38 of our tribes are self-governance tribes. I also wanted to show the map of tribal colleges and universities, because we'll talk about that here in a little bit. So in our service region, we have 2, so Haskell Indian Nations University in Kansas, northeastern part of Kansas, and the College of the Muscogee Nation there in Oklahoma. Okay, so here is my very, very brief overview of CHAP. Again, if you attended Christina Peters' session yesterday, she went into I guess a deeper overview of CHAP. And I know after this session, Martha Ketchel will also be kind of talking about CHAP too. So if you get an opportunity, I think that the presentations really work well, kind of in concert, if you wanted to know more information and have a better comprehensive overview. So CHAP originated in Alaska, and it was created to train local people who were familiar with the culture and village life and that are likely to stay in the community. They are the eyes and ears of the physician. Health aides have taken on an increasing role of providing the provision of primary care services and helped meet the increasing need for healthcare. So their primary care model, and remember, is primary care, dental, and behavioral health are the 3 provider disciplines under CHAP. So the primary care model included emergency care, acute care, chronic care, and preventative health. So this originated in the 1950s from a tuberculosis epidemic. And so they had volunteer chemotherapy aides that gave out medicine in the village under the supervision of a physician. And so they continued to seek healthcare advice through these health aides after that epidemic. So in the 60s, more formal training was offered, and the CHAP program began to take form. In 1968, the Alaska Community Health Aid Program was recognized and funded by Congress, and the program has grown and expanded tremendously since then. So here's kind of a timeline. So again, 50s was the tuberculosis. That word is hard to say this morning. So 50s with the tuberculosis outbreak. I think I'm talking too fast. I'm just gonna thank you. Yeah, I'm trying to just say, I want to be be professional here. I'm just gonna say it all out, Okay, I'm just gonna say TB, but thank you. Okay, so then in the 60s, we had more formal training. 68, CHAP recognized by Congress. In the 1990s, IHS transferred Alaska's health programs to local regional native health corporations through the ISDA contracts. 1998, they built the CHAP certification board and had their standards and procedures. In 2005, they incorporated dental health aides in the dental program. In 2009, they then incorporated behavioral health. 2016 is when IHS seeks tribal consultation on CHAP national expansion. In 2018, IHS seeks the CHAP Tribal Advisory Group, which Christina is a technical advisor for the Northwest Portland area. And Martha Ketcher from USET is also a technical advisor for CHAP, I believe, as well. National area, yeah. Okay. And in 2020, IHS publishes draft interim policy for the national CHAP. And then in 2021 was the first grant funding NOFOs that went out to start funding the expansion efforts. I'm going to talk about what the Southern Plains Tribal Health Board has done through the Tribal Assessment and Planning Grant. There's been two funding frameworks that IHS is using right now, the Tribal Assessment and Planning, and then Tribal Planning, thank you, Planning and Implementation. Please, before we get into this, what did I leave out that was important?
Nothing, you're doing great.
Okay.
Yeah. Better than me, because now I'm just gonna.
Can I interrupt real
That's
quick?
probably the reason why I'm.
Yeah, I know, right?
You said tribal nations that are in the room. Did anyone submit or are submitting for the CHAPTAG? No. Okay.
Yeah, thank you for asking that question. Yeah, that's.
Is anyone interested in pursuing implementation for the assessment and plan?
Actually, could we do like, just because well, let's see, we've got until 11:15, right? And we kind of have a small group. Can we do like introductions, just name and what you do? We'll start with you.
My name is Ashton Montez. I'm a LPN and I'm the health and wellness coordinator for the Chicomee Indian Tribe. So this is really far for us because we have just started our health team up within the past year. So we function solely as a group of 4. Just me and Stormy as nurses, and then we have support. So it's a great program, but it is really far for us. We don't have a position that we work under. We contract with people. And the Chicomee as a whole, we only have about, I think, maybe 25 employees. So very beginning stages of starting that stuff, but it's very interesting.
So on a scale of 1 to 5, 1 being I don't know anything about CHAP, and 5 being
1.
Okay. Okay, good. All right.
Hi, I'm Stormy Miles. I'm an LPN from the Chicomee Tribe and Ditto.
Okay.
Hi, I'm Christina Freed Peters. I'm the Tribal Community Health Provider Program Director for the Northwest Portland Area Indian Health Board, and our program is implementing the community health program for the Portland area tribes, or with the Portland area tribes.
So they just graduated their first cohort of behavioral health aides.
And we have 12 dental health aid therapists in practice. We have, we're starting to pilot community health aid. In 2024, we'll have our first cohort of community health aides, and then we have dental health aid curriculum that we're starting to train the trainer programs with for the lower levels.
And I just want to clarify too, so the slide that I had earlier that had about, I guess, four levels of providers under each provider discipline: primary care, dental, and behavioral health. Northwest Portland has modified that to where there's not as many levels, correct?
We are experimenting with that a little bit to see what's in the realm of possibilities. So one of the benefits of being second, the last is first, is that we have the folks who've had experience within the community health program. We've done a lot. We've had a lot of conversations with tribes about what their needs are. And so one of the things that we are interested in exploring is whether or not we can compress level 1 and level 2 for the community health aid, because level 1 has such a diminished scope of practice and they can't work under general supervision. And it's only like, I think it's 80 hours of didactic training and then 120 hours of clinical training. And so if we squish together 1 and 2, we're wondering if the community health aid, so we're thinking of like primary community health aides, advanced community health aides, and then the practitioner level, and just having 3 levels instead of the 5 levels. But it's an experiment, and we're going to see also question what's in the realm of possibility within the standards and procedures, and is this something that we can do without kind of running to trouble with that national baseline and portability and other things like that. So we'll see.
We'll talk about that a little bit later as well. Okay, so
I'm Kelly Holman. I'm a Cherokee Nation citizen, originally from Oklahoma. I've been working overseas until recently, and we actually did a lot with training girls and young women on being health aides in their communities. And so now we're doing leadership training with girls and young women across Indian country. And when I heard about CHAP, I'm like, oh my God, we could get some of these girls into, you know, this training. And so anyway, that's what I'm looking for, is how to connect the young ladies that we're working with into something more formal like this.
okay, great. So 1 to 5, what is your?
Well,
Uh,
yesterday morning it was a 1, but I went to Christina. Now I'm probably, I don't know, at a 2 or 3 because she gave so much detail. So anyway, I'm very interested in like how we can connect and, you know, tap into what you're building here.
Okay, great. Well, I'm glad you're here. Okay. Just name and where, what you do.
My name is Cameron. I'm the health director at Tunica Biloxi. And whatever my chairman or council asks me to do is what I do.
Good answer. Okay, so on a scale of 1 to 5, 1 being, I know nothing about CHAP, 5 being 2. Okay. 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 Oh,
For the
I'm
people in
sorry.
the back.
Yeah.
Oh, for those who are just coming in, I'm Leon Roberts, General Support Center Director. So if any of you are interested in CHAP and what USET can do to help you out, please feel free to throw cards to the back, and I'll be talking to y'all again at the end of the presentation.
Good morning, I'm Angelique Lister, and I work with Leon with the General Support Center. I'm the Public Health Program Coordinator, so just here to provide any assistance that you all may need, so.
And I'm Anna Miller. I'm a citizen of the Cheyenne Indian Tribe in Winter, California. But I'm born and raised in Virginia too, so I am bi-coastal run, okay? So, I am USET's Tribal Health Program Support Director, very long title. And we are looking at this process. And so that was why I asked the question, was there anyone who was interested? So we are still gonna go forward with the TAP portion of it, but using some internal funds. So we will be supporting our USET tribal nations through this process and learning through. So I'm going to definitely be following all of you through this. And one question I did have is, how much do you all tap into the tribal colleges?
So that was, we're not there yet.
Okay.
And I'll talk a little bit about how we're getting there. But Christina would have more information on the tribal colleges.
So are you tapping more into your local general?
Yes,
Higher
yeah,
ed,
so
okay.
our 2 main like major universities, I would say in Oklahoma, are work with the tribes and with Indian Health Service. I would say pretty intimately. So there's a lot of partnership, there's a lot of programs. So even though they're not designated tribal colleges, they do serve a large American Indian population.
So as you saw on the map,
Yeah.
there are no tribal colleges in our region, and so that's one of the things that we're gonna be looking at. And it's gonna be housed within our workforce development competency, so and I want you all to hear too, and so we are building this and gonna use this as our foundational piece to build out our workforce development and looking for ways to create those funnels for workforce. Looking at the community health assessments, the community needs assessments, your workforce needs, all of those things. And so you'll be hearing a lot from USET about that, so the tribal nations. And just one last thing, I was a part of the advisory group in Arizona. Kim Russell did a lot of work out there, and so in 18, 19, 20. And so I'm familiar with the behind the scenes work and the advocacy that went forward. And the job.
They did a lot of work on dental
Yeah.
there in Arizona.
Okay.
And that's, dental is a bit of a different beast because of the involvement of the states, but I did want to, on the colleges piece, I did just want to add to, like medical education requires a lot of infrastructure, which is often why we, like our tribal college didn't do any medical education. And so for them, they were like, we would love to do this with you. We don't do that. And so, but they did have some existing behavioral health programs. And so that's why we did behavioral health aids with them. But we are looking, there's a tribal college in Montana that has a nursing program. And so we're looking at that relationship for community health aides. But it was really a matter of like, how can we do something that's really expensive as inexpensively as possible? And it's really finding programs that already exist that have the infrastructure, the nursing or the dental in particular, because it's really expensive. Infrastructure, and is willing to do things a little differently with you. We did say no to a lot of programs that were like, well, you could fit into ours. We're like, no, we're looking for somebody who's going to fit into ours. And so that was really, is then put all those pieces together. Do you have the infrastructure? Yes. Are you willing to be creative and different with us? Yes. Okay, let's go on to the next step.
Thank you.
I just wanted to mention, spend a lot of time in New York City now. I split time between there and Arizona. And there's so much health infrastructure in New York City. And I work with Columbia University, their School of Public Health. And I've actually found a lot of Native students who are going there that I'm working with. And so I'm thinking like that sort of setup infrastructure already could be like, a place to look at and, have a conversation with. One among many, obviously. Just thinking about, allies and.
Yes.
Thank you. So I'm happy to talk. if
Thank
that
you,
would be useful.
absolutely, you're on my speed dial.
Okay,
My name is Jocelyn Haney and I'm community health education coordinator for my tribe, the whole band of Maliseets. And I came here because I was kind of interested in the dental because we got like a dental suite, but we don't have a dentist or a dental hygienist or anybody that runs it. And it's like a big need in our community.
level of knowledge of CHAP 1 to 5.
One, probably.
Okay.
I'm Melissa Merritt and I'm the clinic nurse at our health center, I'm a registered nurse and also with the home and the knowledge of Indians. And my level of 1.
You're gonna say 0. Okay,
I'm Sheila Odom. I'm from the Fort Spanish Creek Indians down in Nashville, Alabama. We're the only federally recognized tribe in the state of Alabama. And I don't know a thing about it.
well, we're glad you're here.
I'm Joanne Wilkinson. I'm from the National Big Park Tribe. I'm not a tribal member, but I am the community health nurse there. I've been there for 25 years. We had a community health program we used to manage, and over time it's dissipated. And so now it's starting up again, but it's coming in through a social service department build. They're building the social services department, and we're looking into developing again the job thing of a CHR. And my thing was in the past, we've had trainings that people have gone through, and I've been looking into getting information back on training of that position. Finding it kind of difficult to do that, and also if I'm not there, I guess I'll decide just because the social service director has gone to have a baby, so now the hiring of these people and everything and their beginnings are coming up under me. And so in looking at that, we are it's a difficult place to start. Yeah, all over ground zero to the fact that communities have changed so much in the years that I've been there. And when the other thing that we've been really looking at and as we're going forward, when I first came on as a community health nurse, I was in the homes when the CHRs were under me and we would do home up
Yeah.
there. Now that is a past entity, except that it's coming back a little bit more, and I'm not there in the community because I know them. You're talking people coming into And also, we just kind of like looked at our population and almost 50% of it is under the age of 18. And so there's another issue.
Right. Okay, well, thank you guys. Thank you guys for like going through the quick introductions. I think it's kind of helpful to know where to kind of start in with all this because it is such a large program. So what I'm going to talk about is SBTHB's approach and figuring out, okay, how do we take this massive program and identify the needs of our area and see how that fits, right? And so tribal engagement is obviously super, super important. So this was one of our strategic areas, or is one of our strategic areas. And so what we decided to do is that we were going to partner with one tribe, right? So we're a regional organization. Obviously, we serve 44 tribes, 40, what did I say? 43. 43, right, thank you. And so we wanted to work specifically with one tribe to, again, to listen, to understand, to get a really, really good understanding of the needs, the infrastructure, and how the CHAP might benefit. And so Pawnee Nation Tribal Health System in West Central Oklahoma was very interested in CHAP, and so we started working directly with them. And so we put together an advisory group to really kind of help us understand the needs of the community, to put together survey materials and methods and have them just walk us through starting this process. So that is what we had designed. I think I had said, I think we had like, we wanted, I think 12 advisory group members. So this is what really happened, and these are the lessons learned, because, you know, very rarely do things happen according to plan, right? And so we ended up we had 4 tribal advisory group members, and that consisted of a tribal leader, a CHR director, Pawnee Nation College, which is a super small college that just has a few programs, and his rep, I couldn't get it to go back to IHS. So I was like, I figured you guys would know what I'm talking about. And then an IHS rep from the Pawnee IHS facility. And so we did a lot of broad outreach that was not successful in gaining interest in a tribal advisory group as a tribal advisory group member. But the 4 members that we had were great in connecting us to community events, to administer our survey, and to provide CHAP education of the program. We supported travel to Alaska to learn a little bit more from the programs there in Alaska firsthand, and we offered stipends for participation for those travel advisory group members. So some of the things that we learned through this process is that, you know, there's a lot of competing priorities, and when you have a brand new program, it's really overwhelming to try to learn and understand and kind of put yourself in this position to build something essentially, not from the ground up, but but pretty much, right? And so, you know, having that understanding was important to know. So it didn't necessarily mean they weren't interested. It's just that, you know, there's a lot of competing interests and a lot of things going on. So like I said, broader outreach and engagement was pretty stagnant. And so we needed to have a more targeted approach. And that was more successful for our key informant interviews. And then at that point, we decided that we needed to change course and also broaden our reach outside of the Pawnee Nation health system. So we submitted a change to our work plan to expand to the whole region of Oklahoma, Kansas, and Texas. You know, we really needed an education and outreach plan, but that wasn't really the focus of the grant. The focus of the grant, which again, this was the first iteration of funding going out for CHAP, it was collecting data, it was doing assessments. And so that piece was really missing from us, and it's only a 2-year grant. So I think you could do education outreach for the entire 2 years and that be the focus of your grant. And so That was really hard for us because we're going into these communities and we're having to follow the outlines of this grant that I think are just missing. It was missing a huge component of like, okay, you're asking for this information and we don't even really know what CHAP is. And so that was a huge barrier that we're still trying to work through right now. And obviously, like, it takes time to build relationships and trust. And so, you know, we found that the 2-year grant, the period of performance is a huge barrier because 2 years is just not a lot of time, especially serving as many tribes as we do, to be able to do that. And so that has been an issue. Education and technical assistance. So we have this as another strategic area. So we needed to build some trainings and we needed to build some templates. That way we could have them put together, and anytime they were out in the community, it's just a plug and play, right? And so we kind of just building all of toolkits and trainings and providing initially that training and onboarding process with our tribal advisory group for Pawnee Nation. And we did collaborate with other areas. We had the folks from Alaska CHAP program come and present. It was virtual, but presented during our annual training summit. And so they kind of shared their knowledge and expertise of their CHAP program with our area during that. Hold in-person trainings, report findings. We created a feedback survey for our tribal advisory group members and other individuals in the community. And then also we wanted to present our information at our quarterly board meeting. So this is what really happened. So we built the trainings and we targeted those we built two different trainings, one for community members and then one for the health leaders and the providers. And we provided that training to our Pawnee Tribal Advisory Group. Like I mentioned, Alaska CHAP program presented during our training summit. In the meantime, we had our CHAP program coordinator leave. And so that really kind of stuck a wrench in a lot of our momentum and plans. We presented during our annual conference in April. We had a low response rate to our feedback survey. And you know, a lot of our training and outreach and education stalled with just 2 of us, myself and our public health specialist. So and we had about 15 minutes on the health board of director meeting to talk about CHAP, which is, you know, it takes that time to stay community health aid program and you know, and so anyways, that wasn't a lot. But what we learned is that you have to be flexible as with anything because the plans will change. You got to be able to pivot. The program is super complex and it will be different than Alaska. So you have to identify what are the needs within your within your tribe or your service area, and how can you take Alaska's model and fit it and design it to best fit your needs. And the understanding that each area is working with a blank slate. We're all kind of learning this process and learning this together. Do the best you can with what you have. You have to carve out time and resources for talking about CHAP and doing that outreach. And that's a lot of time and resources. You got to have the staff capability to be able to do that. And what we found is that all of the tools, the PowerPoints and all of our outreach materials, we had to kind of leverage internally with some of our other programs. So if you're going here or you're going to be here, hey, can you take this information and share about it? So we had to get a little creative, kind of getting outside of our own program and leveraging opportunities within other programs within the health board. So we created, and I've only got about 10 minutes left, so I'm going to kind of race through this. So we created 3 surveys. We created a community survey, a provider survey, and a tribal leader survey. And we did that through the community readiness assessment model tool. And we adapted that for tribal communities. And so before we tested that with our tribal advisory group, and also we conducted 3 SWOT analyses. So we did a SWOT analysis with primary care. And so the Pawnee Tribal Advisory Group brought in subject matter experts to kind of talk about the strengths, weaknesses, opportunities, and threats in those areas. And then the same for dental and behavioral health. And so those were super helpful. So we tested the survey and we'll head on to, okay, so what really happened? So I mentioned we brought in those subject matter experts for our SWOT analyses, culturally adapted the community readiness assessment survey, created a scoring rubric for that survey. And then those surveys were tested and vetted in collaboration with the other Oklahoma tribal assessment and planning grantees. So there were 3 in our area: the Southern Plains Tribal Health Board, the Wichita affiliated tribes, and the Kickapoo tribes. And so we collaborated with them on creating these surveys, which was super helpful, just to create alignment on the information that we were gathering. We're still working on the toolkit because we're waiting to complete our data collection. And so what we learned is that you need a subject matter expert to build these surveys with tribal communities in mind. So our program coordinator that left, she was an epidemiologist, and so she kind of built all of that information. And so it was it derailed us pretty significantly when she left. And then, like I said, it was really helpful to collaborate with the other grantees in the area, and the SWOT meetings were extremely helpful. Okay, and so now we have the tools, and so now we're doing the community engagement assessment and administering the surveys in our communities. We're doing key informant interviews with tribal leaders and other key stakeholders, going to community events to administer the community surveys, and doing focus groups with our providers. So again, we expanded outside North Central Oklahoma, and so it's pretty time consuming to travel. And so that's, again, we're having to do a no cost extension because it's taking us a little time to try to get hit our goal and to make sure that we're getting all areas, meeting with all tribes. We also had to do an IRB application for our community survey, which took a little while to get that approval or exemption. And in the meantime, we hired a new program coordinator, and so we got her. She started in May. So we expected to get 300 surveys at our conference because we had roughly 600 people, I think, show up at our conference, and we were really disappointed because we only got 16. And so we're like, okay, we were banking on, okay, we're gonna just knock this out like during this one conference, and so we've had to adjust our plans because we didn't get near the turnout that we thought with the community survey. And so and we anticipated this, but there are significant barriers in trying to connect with your providers. They're seeing patients, they're busy, they're dealing with a lot of other issues, and they don't want to talk. I mean, you've got someone coming in and wanting you to fill out a survey during your lunch break. It's just, it's hard to find, find the time to really have a conversation. So we're going to have to kind of get creative with something after hours or weekends and provide some incentives to talk with our providers. Again, time for background education on CHAP is integral. Again, the 2-year grant timeline is really, really difficult and a big barrier. Again, the specific outreach strategies need to be considered for providers. I learned this at the CHAP symposium: feed them and they will come. So you always have to have food or snacks, and that's always a good way to bring people in and make sure they show up and they stay. And so our survey was actually pretty long because there were a lot of areas that we wanted to measure, and we were offering $25 gift cards for our surveys. So then we're thinking, well, no one wants to take our survey because it's like 40 questions long. Is $25, was that enough? Was that should we reconsider the incentive? Does it match like the time that they're having to put in to do the survey? So this was the readiness assessment scale that that we will be reporting during our for our outcome report on the TAP grant. And so all of our surveys, community provider and tribal leaders will be given a score, and so it'll have a readiness score with each one. So one being no awareness, and 5, 6, 5 is being, we're prepping for change, we've identified needs. CHAP could fill those needs, or 6 being, we're already kind of initiating these changes, and improvements. So these are our preliminary tribal leader scores, so they're really across the board. So I don't know if I have a laser over in here. I'm afraid to touch any of those without moving forward and backwards. Well, so we have 1.8 all the way to 6. So almost. So let's see, 1 being no awareness at all, to denial or resistance to needs or change, all the way to we're already initiating. And so it just kind of shows the diversity of the area that you're serving, and kind of the breadth of when you look at implementing this program with the variation of needs and readiness, can be a little overwhelming. So our work groups have been and partnerships have been integral in kind of getting the momentum and moving this work along 100%. So we developed the learning collaborative, and we did this in partnership with the other grantees, and that has been super, super helpful to connect on what are you doing, what are your needs, how can we help, can we share this, can we share that. Now we have IHS area offices is joining those calls, we have PERSA, we have other tribes that are interested in CHAP, and so we'll start initiating some subject matter experts coming in and providing information into that work group, and we meet monthly during that work group. And so we built a partnership early on with our Oklahoma Healthcare Authority, which is our Medicaid administrator in the state, and so they are committed to working on CHAP, and they've included that in their tribal partnership action plan for next year. So we're really, really excited. And what we're focusing on is CHR CHWs and developing that out with the state, because right now CHR services are not currently reimbursable by Medicaid. And so we'll also be working in concert with the state health department, because they're working on are doing similar work. The folks in Washington, Oregon, and Idaho are fantastic and always willing to hop on and help and provide guidance. And so we're excited to have them on one of our upcoming calls. We did a social media campaign just to try to share information and resources. And so that was an 8 or 9 month campaign through our SBPHB social media platforms. We also did a short animated video to share, which just kind of broached on the subject of CHAP, but we'll have a second video, will be a 5-minute interview based video with folks from Alaska. Christine will be the rep, and possibly one more from Northwest Portland, and then we'll have a couple of tribal members, tribal leaders from the Oklahoma area that'll be on that video as well. So that should be done, I think, the end of this year. Really quickly, so we still have to finish our data collection, still doing education training, and doing our outreach with tribal health directors. We'll be going into a logo development and website and kind of branding of our programs. Excited to be able to host a workshop with Northwest Portland, hopefully next year or the year after. We'll be focusing on behavioral health portion first. We've decided it makes a lot of sense, and learned a lot from Northwest Portland to kind of piece the rollout of the program and start with one provider discipline, and building on the others. And so it's been really, really important for us to identify ways we can leverage already built infrastructure internally. And so we have an annual training summit that we're doing some analysis on to see if we can evolve that into a training site for health aides. And right now the National Certification Board Christina, correct me if I'm wrong, but they will be using the Northwest Portland Area Indian Health Board standards and procedures as a baseline in the interim for standard for areas. So we can use that as a baseline when we're looking at curriculum development and in partnership with programs. And so we'll use that. So we don't want to lose momentum. We want to keep moving. And so headquarters is still trying to kind of get organized, and so we're wanting to just, and the advisory group does a good job of making sure that there are processes in place where areas can still continue to move forward with the planning and implementation. So through our training summit, we already partner with the University of Oklahoma Health and Sciences Center and the Hudson College of Public Health, and we also just this year started partnering with Oklahoma State University. And so through those two partnerships, we're able to provide CHES 1, 2, and certification of public health, or CPH, continuing education credits. So those partnerships will be super helpful to kind of leverage and build into the CE and the training infrastructure for health aides. And so we've already had conversations with both universities and have meetings set up to talk about, okay, how can we build a health aid program, and again, leverage this partnership with the training summit and the CEU process, continuing education unit process. We're going to be producing an area report, again, with our findings that includes the tools that we've created for our tribes in our area to utilize for their own assessment and planning efforts. And so we're going to be partnering with the Wichita Affiliated Tribe to produce this area report to provide some guidance for our area. And so the next phases for us in terms of area infrastructure development, we have a tribal consultation that will be in November, where we'll have some time on the agenda to talk about our accomplishments and where we're doing, and a status update for the area office. It's so important that you have alignment and you're engaging with your area office folks. And so we've done that, and we've to this point worked really well, and it's been a good partnership. We'll be developing a CHAP work group that is representative of our area. Our area certification board, we already have one person seated, and so that's yay. And again, working on through this work group, developing these academic review committees, reviewing the standards and procedures and training programs, curriculum development, this regulatory oversight, and how we're going to offer technical support. Also looking at SDOH, social determinants of health factors, and provider retention and recruitment. And again, how can we leverage the built infrastructure internally, and doing an analysis to be able to identify those. Dental therapy is something completely, even though it is under the CHAP umbrella, it's completely different because it requires state legislation for dental therapists to be to practice, whereas CHAP providers is a tribal program, and it's a federal certification. This is different. We're trying to bring this to Oklahoma, and so the American Dental Therapy Association conference is going to be in Oklahoma City, and excited to bring in some Oklahoma stakeholders and talk about this provider that is so needed in our state. So key takeaways. I'm sorry, I'm like a few minutes late. I'm gonna do this really quick. So leverage built infrastructure with our oral health, and dental programs, is we're going to leverage that built infrastructure. Our behavioral health programs that we have internally, we have a lot of a pretty robust behavioral health programs at the TEC. Our established partnerships with academic institutions. Be patient and flexible. This is new, and so there's a certain amount of grace we have to all give each other in this process. Seek out partnerships early. It's okay to plan these components of CHAP overlapping, right? Like, even though, you're not ready to certify, or maybe you feel like the training or curriculum development is too soon. If you have people that are willing to meet and work with you, you need to start doing that now. Build it and they will come. I think just because it's a new program, and again, there's a lot going on. And so there's a lot of tribes that are like, okay, once you get it a little bit more defined, we're gonna come in and we'll see how this fits. But you know, you keep building it, you're doing great, but we can't really be involved right now. And so that's kind of where we're at with that. Diversifying funding is super important, and I got that advice from Northwest Portland. Taking time for relationship building and community engagement. It's not a sprint, it's a marathon, but there are little energy bursts and sprints in that. So thank you to Alaska Native Health Consortium and the Northwest Portland Area Indian Health Board, because they have been so important and such a valuable partner in figuring out what we are doing. So thank you guys. I'm sorry I went over.
Does anyone have any questions for Julie as we wrap up? If not, that's perfectly fine. Just want to thank you, Julie, for your